Good afternoon and welcome everybody to our Woulgan afternoon meeting. It's a pleasure for me to share this meeting together with my two co-chairs, which I will present when they have their presentations. The meeting is about local wound conditions, local wound treatment, and I will have a first introduction into this with the question, how is the local impact of non-healing wounds, followed by two more specific presentations on Woulgan and also on the wound conditions. This symposium is supported by Woulgan, is obvious, and I don't have any other interest with respect to the presentation. But I'm keen to discuss with you and also to listen to the other talks about this new component in the treatment of chronic wounds. My presentation will introduce you into this by providing some interest and knowledge about wound entities, wound healing, the need for wound management, some standards, and also consideration how and if we should make use of the innovation pipeline in wounds. Starting again with the question which wounds we are talking about, and you know that there are many different perceptions on this also depending on where you're working. Probably you're not working in such a center, which was maybe the standard in the 15th century when wounds mostly meant wounds that were damaging because it was artificial and followed war or any other terrible things. Today, still we have acute wounds of different sizes which are healing in a small period of time, which do not deserve further attention except of keeping them as clean as possible. And then we have those delayed wounds which have a prolonged healing time, which may be infected, like this surgical wound you see in the picture. But we are talking today about the stagnating wound, the chronic wound, which doesn't show signs of healing for a period of time, but also which is based on a pathology of the tissue, not deriving from previously healthy skin. And this is a typical 55-year-old female patient with type 1 diabetes and a non-healing wound, as you see. And maybe it's a little infected or sludge on this, and the cause has been deep inflammation of the skin in this case. So such wounds are what you're familiar with. And the challenge is that these wounds do not are directly referred to us as experts, but in a previous study regarding community ulcers, we saw that patients on average who were treated in the community had an open wound for more than 2 years in the Hamburg area, and the disease duration, including the underlying condition, was more than 8 years, as you can see. So obviously there has not been a precise and immediate intervention in these patients. And I think this is what is the risk for all patients having wounds like these, chronic wounds that you're familiar with. They are aged, they are multimorbid, they have multiple etiologies, a high patient burden, also high economic burden, and they missed to be treated at an early time point so that these wounds could escalate. Regarding the pathogenesis and then further look into the physiology of the wounds, you know that the final result, tissue damage, can derive from many different conditions, both vascular conditions, inflammatory conditions, those being of physical origin like chronic pressure. We need to look after this before we really start intervening. And just focusing on leg ulcers in the next slides, it's for sure that the underlying cause needs to be identified before going into details, and this by probability means that most of the wounds that we can expect are of vascular origin, but there's a marked number of wounds which also have very different underlying condition and need to be treated differently. And so in such a situation, we need to make sure that we are on the right track and haven't missed another diagnosis. Regarding the local impact of such wounds, there is a rich and very complex pathophysiology which may be a focus in the next presentations, but just to remind you that also acute healing doesn't happen all of a sudden, but in a series of events which are when described like fibroblast expansion and differentiation, proliferation, which is lacking in the chronic wound. Here you see the comparison, acute healing, chronic healing. There's a delay in this and in many other cellular components also, like in the keratinocytes. But some cells are dominant, like the leukocytes, which are more in number in most chronic wounds and can put damage, also macrophages. And finally, there's regarding the cell component, there's a deficit in angiogenesis in chronic wounds compared to acute wounds. There's damage in chronic wounds based on reactive oxygen species, MMPs, and also maybe bacteria, which may be damaging to the wound as well. So it's a series of events happening, and some of the cellular components of the different specialized cells are key. For example, the leukocytes, which lead to an elimination of damaging components, the complement coming from proteins, the lymphocytes leading to immune responses, the monocytes differentiating into macrophages once leaving the vessels and then contributing distinctly to the elimination of microbes, but many other factors which we will learn about in the next presentation, and fibroblast producing extracellular matrix, which is a basis of repair. So these cells are important. None is more important than the other, and it's the concert between them which makes wounds heal or not. And they are signaling not just in direct touch, which we call adhesion, but also by signaling, by communicating with a large number of factors, which I don't go into detail, but there's plenty of, and we will discuss this later. I just want to remind and summarize the pathophysiology of the non-healing wound on the right compared to the physiological wound, that on the one hand we have the risk of infection, local infection, we have high proliferative epidermis but no signs of complete epithelialization. We have persistent inflammation. It's a key problem to deal with inflamed, not just infected wounds. We have a senescence of fibroblasts which get lazy enough. We have impaired angiogenesis and fibrin cuffs around the vessels. And finally, the MMP is elevated and disbalanced. So this is a series of problems which sometimes interact and which we need to identify in those wounds. And wound healing then happens if those problems are overcome in different stages or healing phases. We know those wonderful pictures when wounds start to granulate or to develop epithelium. This is what we want in our wounds. And we are realistic enough to know that 100% wound healing is not the only goal in a wound treatment of chronic wounds, but we need to be modest and follow several steps. So one interim's goal could be just to have a clean wound, to have readiness to graft, to be able to debride, and across all those phases, as you know, there's the need for infection control, exudate control, and pain control regarding the patient perspective. So this is a lot of work that we have to do, and so there are specific needs in wound management. We need to be comprehensive thinking largely, and we also need to include the patient in this large thinking, because in many ways wounds are very individualistic and specific, and the fingerprint of a patient can also well be reflected by the way the wound extends and he feels with his wound condition. And we should be realistic to also include the patient needs and the patient potential goals of treatment into our doing, knowing that complete wound healing is a very important goal, and we know this from large studies that we have done in Germany on chronic wounds. Almost all patients say, yes, of course, the wound should heal, but beside of this, there's a large series of other important goals like less pain, also no exudation, no bad odor from the wound, having no fear of disease progress, or be less burdened by physician and clinic appointments. Very remarkable. We always were disappointed with this answer because we thought we are needed in all cases, and the more they see us, the better. But patients tend to want to be independent, of course, and want to be driving their development themselves. So the note here in the conclusion is patients have a large number of needs which need to be identified as single treatment goals. We can make more of it when we define the goal, identify the need, and then try to achieve the goal. Regarding the approaches that we have in chronic wound healing, you will surely agree with me that there need to be standards both in diagnostics and treatments. And this is a typical case, really also scaring case, where no standards, no specific approaches have been driven. This was a patient I saw in our intensive care unit at the University Medical Center in Hamburg in Germany. And this patient was admitted to hospital with the diagnosis chronic venous ulcer, and you immediately see this is the foot, the back part of it, that this is no venous ulcer. It's not even a leg ulcer, but a foot ulcer, and a massive one with massive edema. And you don't need much time to see that this is not a primary vascular wound. This was the regular one. It was a severe vasculitis, and the patient was admitted to intensive care because there was acute kidney failure. So when at the earlier time point, one of the community physicians of the GPs would have realized that there's more need for action in these wounds, the patients could have avoided this severe case and barely survived this whole issue here. So regarding local impact, we need to identify what and get as much information from the wound as we can, and then there can be many different options, like I have shown before, with a large proportion of vascular, but even many other forms of ulcers. Hundreds of options possible. And now, having done this, having a clear concept of treatment, of treating underlying conditions, then we can move to the wound and check how the wound condition is. And it's very helpful to also follow a standard here and a systematic approach. And EWMA has for long positioned a paper saying that the time scheme may be of favor, and you may know those points. And I quickly go through this because it can be helpful. But nevertheless, regardless how you do it, it makes sense to accurately follow different steps in the wound investigation. One being looking at the tissue, which here, as you can see, includes fibrin, it includes epithelium here, granulation in tiny areas, but especially necrosis, and this needs to be described and conclusions being drawn. But this is just the tissue in the wound. Infection or inflammation means to regard the wound and check if there's a risk for this. And as you can see easily, there's erythema around the wound, which is a sign of inflammation. If you touch it, it's very painful. This is what you cannot derive from the photo, of course. There's desquamation, that there has been probably fluid here so that the skin desquames. Regarding moisture imbalance, you see that there's a balanced exudate, of course depending on the time point when you remove the wound dressing, but there's also xerotic skin around in these areas here, so it's not really balanced and needs further consideration. And finally, as you know, time also includes the wound edges, which are very helpful to investigate because acute and active processes can better be seen here at the edges than in the middle where the process has already been done. And what you can see here is, on the one hand, necrotic margins, like here, there's necrosis, and there are also inflamed areas here, which show that there's activity in this wound, which, by the way, is what? What do you guess? Dermatologists should know. Pyoderma, yes, BB knows it, yeah. Pyoderma gangrenosum was the diagnosis here. So, following this and being systematic in diagnostics, of course, treatment is the next step. And as you know, we cannot standardize wound treatment as we could with drug treatment. If we define the drugs to be uptaken, then there is some standard in it, and it's repeated in dose and in the way of application. And wound treatment starts with variations in the way bandages are positioned, and continues with many more variations than in drug treatment. And so in reality, we need to be very flexible, standardized, but also working in a personalized way. And this is just a snapshot on 20 wounds in 1 or 2 days of our wound clinic. And in these 20 wounds, we used 12 different wound dressings, because this followed the conditions and the needs in those patients. And the criteria for choosing different ones rather than having one unique are mentioned here, from wound type and pain status, wound edges, exudation. They all contribute to decisions which then are individual, and doing so we have predictors of healing outcomes. One, we find the best combination. But nevertheless, there is the need for standards, in that we are aware of the evidence about what we know and what has been shown to be effective in defined wound conditions. And this is a recent meta-review, a systematic review on systematic reviews of wound outcomes from the Netherlands. Maybe one of the authors is in the room, because they are all from Amsterdam. I would have loved to have them here, because it's a very nice systematic review, and it summarizes our overall knowledge, which in single cases may be divergent from what we see in a patient, but as you know, there is evidence for more than we expect in wound care, and we should keep this in our mind. And finally, we should be aware that there is a pipeline of innovative substances. We need to be critical with them, because they need to provide evidence and the proof of concept. But we know that new upcoming technologies with proven evidence have a special place once they are superior, and then we should also dare to invest more and pay more if they prove to be superior to other options. And this is what sometimes is lacking, especially from the payer perspective. And I like to show this scheme for this. This is schematic, and we published this as an example in The Lancet some years ago, which shows that if we just look at the wound treated properly but traditionally, without risking any further, let's say, additional treatment, where mostly the wounds keep like this for years. But if we use advanced technology, even if there are higher costs initially, this can work out in lower costs and a return on invest on the long term. And this really happens, and examples for this are compression treatment. The lifetime costs for compression treatment are lower than leaving out compression in patients with venous leg ulcers. Topical negative pressure, some other treatments like electrostimulation, tissue engineering, beta-glucan, they also are a sort of invest at the beginning in order to break through the stagnation of the wound and get into a more active phase. So the message here, we need to invest in rapid transfer from wound stagnation to proliferation once we want to be successful. And the last point, which has to do with this, is that we need to be early and alert when patients come with upcoming wounds or with conditions in risk or at risk of getting a wound, like severe edema or like arterial occlusive disease, which may not result in a wound yet, but the risk is there. And then at this point, we need to react early. And this early intervention, compared to just sleeping and waiting too long, is associated with saving the patient from higher costs and the payers, but also with saving the disease burden to the patients if we are early enough. And so the message here, there are avoidable costs upcoming which are raised by late intervention. Don't lose the opportunity to react early. So coming together and landing up with my title, The Local Impact of Non-Healing Wounds, you have seen the many facets here, and I guess that you would agree with most of this. The rest is for discussion, and I propose that we have a discussion at the very end so that we follow the next two presentations and then have a panel here. So at this point, thank you for your attention. Now it's my great pleasure to announce the next presentation, which is by Ron Legerstey, and he will talk about the central role of macrophages in wound healing and their activation by bioactive beta-glucan to restart healing. We are looking forward to your presentation. Please run.
Thank you so much. Thank you so much. See if this works. Yeah, it's loading. Thank you so much to Woulgan for inviting me to present on the central role of macrophages in wound healing. I must be honest and tell that until recently I didn't hear about beta glucans. Um, I don't know how many of you have heard of beta glucans or glycosaminoglycans or proteoglycans or glycoproteins, or if you read any textbook about the basic concepts of wound healing, you will meet those terms. And there are some nice things to tell about. Obviously, we are talking about wound healing, so we exclude about talking about broken bones or cartilage, or this is exclusively healing of the wounds of skin. And you see here, in my opinion, the most beautiful and freely available picture of a piece of skin. Wouldn't you agree? With all the detail, and of course you have to attribute to the makers, which is Bruce Blausen Gallery. And there are on internet there are many more wonderful pictures you can use for presentations like this freely. Professor Augustin has shown many types of wounds. This is a collection of my experiences in 20 years, and you showed the same amount of wounds in just 2 days at your office. So obviously there's what expertise is. I'd like, rather than talking about many different types of wounds, I would show a more systematic approach. And this is also one of my ways as a 60-year-old to show to younger people that I am capable of talking in emojis and pictograms as well. This is a development that lasts over a decade. When I teach in Rotterdam, I ask students every year to tell me if they have a proposition to change one of these pictograms, and the last 2 or 3 changes were indeed made by questions of students, and which is interesting. Sometimes they try to bribe me to make a change, but there's a little more needed to do that. Here you see, and that's maybe also important to say to a group of experts in the field, that most of the time you get to see wounds or pictures from problematic wounds. And almost never do you get a picture of a wound completely healed, completely closed. And that's a shame, because you can use that for teaching purposes. So I literally haunted the mother and the mother of this child, this boy of 13. In the first picture, that's the day of the accident after cleaning and closing. The second is on day 8, when the stitches were removed, and you see that much of the rubordo-localar tumor sequels are gone, except for the tumor. So apparently there is, at day 8, after removal of the stitches, still a lot of stuff that needs to go out of the system, out of the, in this case, middle finger. The third picture is after 7 weeks, the fourth at about 7 months, and the last one, photograph E, is exactly 365 days after the injury. So here you see a complete natural history of a healing wound. What appears to be a problem in the last picture, he is now 14 or something, is that he has a contracture over the finger, and that's because you cannot expect a 13-year-old to keep the scar supple over a period of a year. You don't do that with a 13-year-old. So he didn't, and now he's in reaching puberty, and he has probable the need to have some medical attention for clearing that problem out. Here you see, in another way that Professor Augustin showed, another model of wounds, of the wound healing process on the left, but that's been covered already. I have put this in to bring to your attention. On the bottom pane, you see macrophages eating bacteria. So and at the top you see a fibroblast pulling on a keratinocyte. So it's actively pulling on other cells to close a wound. Isn't that amazing? And also recently, it was published last year only, that fibroblasts can be seen live in modern technology to pull existing blood vessels into the wound. They weren't even there. You can't wait for new blood vessels in neoangiogenesis. Then at first you just start pulling on existing vessels. And then you release substances so that new vessels are being formed. And we can, at the bottom, we can now, with new, but also with old microscopy techniques like fluorescence and labeling of signaling compounds, you can exactly show in live cells which cells produce what and which cells are responding to that. And so that opens up a whole new level in our understanding of wound healing. On the left, you see a free living cell, which in this case is a macrophage derived from the monocyte. And on the right pane, you see a cell still attached, which is not visible. I must call that guy Blausen. Could you make this same picture with 3 cells? So I can explain that the interplay of wound healing is because you have cells performing on their own and interacting with cells still making part of the tissue. If we are able to disturb wound healing, or are we able to disturb wound healing? Yes, we are. And here are 2 rows of ways to do that. And obviously there's also a psychological way to do that. It's funny, in this book of Upton and Upton of 2015, there has been a test performed in the UK where the saliva of people were compared with wounds. The saliva, the cortisol levels in the saliva were compared of those who were treated with old-fashioned material like cotton gauze, sticky stuff, tearing off the wound, causing pain, and it was compared with the cortisol levels of people who had who were treated with foams and alginates. And obviously, the cortisol levels, the stress hormone levels in the saliva of the people with old-fashioned material was significantly higher than those who were treated with the modern. Does that amaze you? Huh? Well, it is not published in an RCT. These types of studies do not reach meta-analyses of RCT. Oh, okay. Okay, thank you.
Fresh for you.
Thank you. So I would suggest that information, may I ask you, such a study about the cortisol levels in saliva, would you think as a professional that is significant evidence to do this or do that? Can I show hands? Would you? Okay. Well, I don't see that much response, but I would scream yes, personally. But okay, then I advise you to buy this little booklet and to see what psychological impact does to wound healing. Both the previous presenter and I presented a model of wound healing, and there are very many models of wound healing, and this is the other way around. What if something goes wrong, or some decision is not made in time or too late? What happens then? Well, then you enter something like something that seems or resembles a vicious circle, which is not, but we often tend to think so. And from there is derived the term chronic wound. And Professor Guido Maino told me in 2005, and he was a professor in pathology, he said, Ron, chronic wound is not a good term. It's a medical misnomer. And I said, well, if I jot down chronic wound in PubMed, I get 35,000 hits. And then he was silent and said, is the amount of hits for you, does that equal the amount of truth? And I said, ooh, I was getting smaller all the time. I said, well, so what's the alternative? And he went further, reasoning, you either die from a wound or you heal it. So every biological organism has to heal its tissues. And I said later on, this discussion took on a couple of months, and once I asked him, could you have an alternative for us then? And he said, why not name it complicated wounds? Not complex, not non-healing, not slow healing, not recalcitrant, therapy resistant. There are about 12 names for these types of wounds. Why not call it complicated wounds? Because something is obviously keeping this wound from healing. And I thought, wow. And then you can use a picture like this and say, on the top left, you can say, if bacteria are constantly entering the wound, the cells are constantly forced to do something else that they were designed for. You know, and you keep having polymorphonuclear leukocytes in there to combat with the bacteria. They use up all the oxygen, free radicals or reactive oxygen species, as in the previous presentation. They are released, and then other cells die. And if cells die, they lose their content into the environment. In this case, lots of enzymes that break down proteins, and you get, on the left top, you get the extracellular matrix constantly being destroyed. And what is more interesting for new species of bacteria, if you yourself are destroying the proteins which make the granulation tissue, for instance. So there you have this vicious circle, but it's not, because if you take it out or you influence the extracellular matrix, which is what the company with beta-glucan is trying to do, then you show that it's not a vicious circle, and you can proceed with the wound healing. And also, of course, bacteria. I cultured this biofilm 2 years ago in a period of 6 to 8 weeks from fresh water, and this is what happens. And this is, live. I didn't tamper with the time. It's not a time lapse. This is how fast they go. This is how big they can be. It's not 1 or 2 microns. Yes, dead in a petri dish maybe, but not in a live situation. Here's one trying to measure up itself to see how big it is with the bar. On the left, this is a wonderful presentation, and it's not by scientific community. Yeah, it is scientific community. It's not a medical university which produces. This is actually a company that sells substances with which you can label cell cultures, and you can exactly check which kind of molecules are being formed after specific types of triggers. So you can annoy a cell culture and then hypothesize how the cell will respond. And each single combination of molecules will light up in any color that you want in live cells. And this is interesting because has anyone heard about DAMP and PAMP? It's damage-associated molecular patterns and pathogen-associated molecular patterns. So each and every cell in your body knows the difference between factors from pathogens or factors from damage. And it responds accordingly. And all of these disease states, but in general it all says inflammation, it says it all really. And you can make use of this new knowledge to have new treatments. In the middle, this wonderful picture, I think, of unicellular plant cells, yeasts. They make beer, they make wine, they make in all processes of fermentation. You use this. And on the left pane, you see mushrooms, oats, seaweeds, Candida albicans. So both physiological cells, pathological cells, organisms. Many plant materials contain beta-glucans in their cell wall. And here you see the complexity of a protease, which is being broken down at high levels in complicated wounds. And here you see the relatively simplicity of a molecule of beta-glucan. And I've been told today, because I wasn't aware of that even the length of the chain of the polysaccharides matters. The company has cut these molecules at several lengths and try to see what the effects were on the healing process in wounds. And exactly what they have come up with this beta glucan product of Woulgan is exactly the size to stimulate the macrophage type, because there are 2 or 3 distinct macrophage types, to stimulate the macrophage which is predominantly active in the proliferative state of the wound healing. So you actually can reason with a product like this that you stimulate the wound healing. And how many of you are from the UK? Can I see hands from the UK people? According to this bit of news, half of you have had beta glucans this morning in the porridge. And it's the substance that makes a certain type of gel. The walls of many oats do that. The group here somewhere at the Heineken brewery yesterday evening, and you actually could see how the oats jellified under the influence also of yeast containing beta glucans. Hence, the circle is round. There is much more of scientific literature to underpin the importance of the use of molecules in wound healing. And I was fortunate to be sent some of this very interesting stuff. And I think it's because it's in here and you get it on the site, probably it will be available for you to dive into this deeper. I thank you very much.
Thank you, Ron, for this excellent talk. As I said, we discussed in the end. And, I'm sure that there will be questions on that. So thank you for now. And now it's my pleasure to announce the last presentation by Brenda King on the bioactive beta-glucan in clinical practice, case reviews, and proposed treatment plans. Please, Brenda.
Good afternoon. I have to stand to the side. I'm not tall enough. There you go. I'm going to talk about the case studies of using beta-glucan in clinical practice. And there is a conflict of interest. I've been funded to actually come and speak and also to do some of the evaluation. We've heard quite a lot about different wound types and this idea that we have wounds that stall in the healing process. And you'd think if we get the diagnosis right and we get the right treatment for whatever that diagnosis is, then wounds should heal. But clearly that's not happening. We know that there is an increasing number of wounds out there, and we know certainly in England that 60 to 70% of wounds are being managed in community, and we know that that's part of quite a wide range of jobs that the community nurse has. And whether we have got the skills to recognise clearly when a wound is going wrong in that healing process. And I think that is some of the challenges that we face. Understanding why that acute wound may become chronic. And when we look at this in particular, there are clear reasons why that acute wound on the back of somebody's leg will become a slow to heal or non-healing wound, because we need to treat other underlying problems. So there are times when we need to recognise that if we don't treat differently, it will become stalled. But we also know that it doesn't matter what kind of wound it is, that we may well see the wounds that start to become prolonged. So we see surgical wounds, and surgical wounds that are months. The image, the top right-hand side is a 6-month non-healing abdominal wound. The pilonidal wound below it, and again, a wound that's gone on for months with non-healing. And what we need to sort of think is how and at what point can we recognise that that wound is not progressing, and do we have the skills there, or do we need other ways to actually think, well, this wound is now becoming more of a chronic problem or more of a delayed wound healing. We heard that about inflammation, and inflammation is essential for wound repair, but often the wounds that we see display this abnormal chronic inflammation. This is actually a non-healing donor site, and it's 18 months old. It's quite an old image, and I like to think that we don't see anything like that. But once that wound gets into that chronic cycle of events, or that chronic inflammation, then we need to be thinking about what can we do differently to actually get that wound back on track. The bioactive beta-glucan, there is evidence out there about its ability to reactivate some of these stalled wounds. And there has been previous studies and also previous evaluations. What I wanted to just feed back was on the UK evaluations that took place last year. And the Woulgan gel is in a type of hydrogel, so it has all the benefits of a hydrogel, providing the moist environment. It actually soothes and is quite comforting from a pain perspective, which was something that, the pain scores did improve significantly in the patients that were evaluated. And it's also got this soluble beta-glucan in there that has been demonstrated to stimulate angiogenesis, to enhance cell proliferation, and also increase the ability of wound contraction. Started with a focus group to get a group of senior clinicians to discuss what problems they had in their particular areas with regards to stalled wounds. So there were TVNs and podiatrists in that group, and they then went on to actually do some evaluations. And it was a 12-week evaluation period on wounds that had been non-healing at 4 weeks, so was showing no signs of healing. 26 patients met the criteria for inclusion into that evaluation process. And in the 12-week period, 27% healed, 30% of the wounds reduced by 50% in size. 5 wounds demonstrated some moderate improvement, 6 did not respond at all. Following the 12-week evaluation, we looked at the wound healing or any further progression, and a further 3 wounds healed after that 12-week evaluation period. We had a few more male subjects, the mean age of 71, but there's quite a wide range. We've got a young person in there at 27 and then somebody at 93. The majority were leg ulcers and of mixed etiology. We also had 4 diabetic foot ulcers, 1 pressure ulcer, and all had been receiving what would be seen to be standard care: compression therapy for the venous ulcers, offloading for the diabetic foot ulcers, and also for the pressure damage. The wound age varied between 4 weeks and in excess of 52 weeks, but over 80% were 16 weeks or longer non-healing wounds. And of the wounds that healed, the leg ulcer with mixed etiology with a 32-week age at start of treatment healed at week 8. Ischemic diabetic foot ulcer, 4 weeks duration, healed at 12. Surgical lower leg ulcer of 16 weeks healed at 6 weeks. Pretibial laceration, and these were in compression therapy prior to treating with the Woulgan. A dorsum foot, diabetic foot ulcer of 5 weeks, healed at 2. A 4-foot amputation, quite a long-standing wound of 312 weeks, which healed at 9 weeks. And then a leg ulcer of 14 weeks that healed at 7. This is the pretibial laceration. Week 0, it had been static for 12 weeks, and then at week 4, and then healed at week 8. The surgical incision, it was a post-orthopedic surgical wound, over 16 weeks in duration of the wound, but it had been static in healing for some time, and that healed at 6 weeks. The diabetic 4-foot amputation, and this is the wound that had been around for quite a number of weeks, healed at 9 weeks. The diabetic foot wound healed at 2 weeks. So we saw some really, really interesting things and some, significant improvement on some of the wounds. It was interesting to listen to some of the clinicians' comments. There was a comment in one of the clinics, I think they named it Wonder Gel at one bit. Comments like never healed over a number of years, an expectation prior to trying the product was that it wouldn't heal, the wound wouldn't heal, or they thought the healing might be slow, but felt that Woulgan had actually improved that healing rate. Unsure whether the gel would make a difference, never healed in 6 years post-amputation. So quite a few, interesting comments from that. And then thinking about, proposed treatment plan, and I suppose if you think that we need the skills of people who are doing that as an everyday job to be able to recognise when wound healing is going wrong or when wound healing is stalled, perhaps we need to be looking at the duration of the wound as a marker for when we might intervene, rather than getting people to recognise changes in the wound bed or changes in the appearance of the wound. And if it's suggested that wounds with a less than 40% reduction in size at week 4 and they are already receiving standard care are considered to be stalled, perhaps we should be thinking about active treatment at that 4-week time period. Woulgan can be used for up to 8 weeks or as long as the wound is actually healing, and can typically twice a week. Some of the ones that were in the evaluation were just treated weekly. But then obviously if there's no improvement with that Woulgan, then to discontinue. I think we're likely to see more wounds. We've got an increase in elderly population, we've got a more comorbid population, we've got the potential for more wounds become installed. We've got to think about how clinicians recognise promptly when a wound is failing to heal, and how we can activate some alternative management to try and support that wound repair. Certainly we saw some very interesting outcomes with the evaluation, and it did demonstrate some potential to boost wound repair and to sort of increase that speed of wound healing. Thank you.
Thank you very much, Brenda, for this excellent presentation. Now all 3 presentations are open for discussion. Who wants to start? As usual, it takes some time until people collect, but there's the first one. Do we have a micro, or just in the... Yeah. Okay. Please.
Professor Augustin and your fellow speakers, I want to congratulate you on your approach. There is absolutely no question that if we can push the inflammatory phase more into the proliferative phase, that we speed up wound healing. And we continue to hear this gibberish and nonsense from the various committees from, peddling the biofilm story. It's so much more refreshing to see that we're actually using the pathophysiology of basic wound management of the wound. I have one question, and it is purely to try and explain how pushing it from the inflammatory phase into the proliferative phase might or might not work. And I too agree with you from my long practice in the wound clinics in Australia, where I come from, that the key element of the inflammatory phase is the macrophage. And then we have the key element in the proliferative phase, which is the fibroblast. And if we can enhance fibroblast proliferation, of course we're going to move that along, regardless of what the heretics peddling this nonsense about biofilms is. And do you think there is any connection between a macrophage and a fibroblast? For example, since the advent of molecular biology only in the last 5 years, we're now getting the picture of the wound healing story ever so much more correctly, if I might use that word. And do you think that there might be a situation where the macrophage actually becomes like a chrysalis, the fibroblast?
Ron, do you want to comment on this? Otherwise, I take the next answer. Is it something which you want to...
Thank you. And thank you for raising the issue of using common sense like pathophysiology and biology. You couldn't make my day more than this. Thank you, sir. I'm not sure. I think cells can differentiate, and indeed, in the last 5 years, we've seen so much of our standard thinking proven wrong by these cells. I think it's possible that I think we know already that macrophages are very much in the center of the healing process, and it gives orders to cells, it takes orders from other substances. Whether or not it could differentiate into a completely different cell type, that I do not know.
The reason I bring up this very topic is that the proponents of things such as biofilms and all the other comorbidities, if you like, that stall a wound, are advocating debridement, surgical debridement, and even though when they surgically debride it and find that there's biofilm still living there, or still there, they're then advocating more surgical debridement. When do they accept that they're wrong? Yeah. So the situation here is that if we can get the macrophage, or identify that it's the macrophage converting into the fibroblast, what I'm saying is that if you then go and debride that, you're going to stall that wound by taking out a very valid natural step, yeah, which they just don't seem to understand. Yeah. With all the eminent people on their committees and all the rest of it, they're ignoring the basic facts about what we know about pathophysiology of wound healing. And I think it's so refreshing to hear you people using this very basic element and saying this is where we should be looking for stalled wounds and the explanation to stalled wounds and progressing them from there.
Thank you. Thank you.
I think thank you from my side that there's a narrow gap between damaging and supporting wound healing by debridement, for example, and we should make use of it when indicated. But I agree with you that we also need to be aware that it's the cellular components and their interaction which really drives the process in the one or other direction. And I don't know if it's a must that there's a transformation from macrophages to fibroblasts, but more of an interaction. We know that both macrophages and fibroblasts are pluripotent in many ways, not just by producing and releasing wound healing factors and which interact, but also by changing their functionality, like myofibroblasts in the sense of fibroblasts. And so this diversity obviously is needed for proper wound healing and for stretching out from an early into a later phase of wound healing. I think this was your point. And obviously it's not just one single factor which we should increase, but it's an overall one. And now coming back to Woulgan, to the beta-glucans, obviously they have the capacity to improving the phagocytosis and functionality of macrophages and their activation status in the wound in a very specific way. It's just a certain type of glucans, and maybe others can explain this better, but which have the capacity to inducing both the differentiation and the functionality of macrophages. And obviously these cells are key in the process. Are there more questions or comments? Otherwise, I would like to ask Brenna, now having your clinical experience with Woulgan, can you precisely describe patients where you would apply this component first? I mean, when we get something new, we started at the most desperate patients, those where everything else has not been effective, and so it's a little unfair to start like this. But over time, you may have emerged a good sense of where you would use the product. What is your notion on that?
Yeah, we had a discussion earlier actually about whenever you see something like this, you tend to use it on the worst case scenario, and I think we need to be thinking, and again the idea that we wait for 4 weeks. Should we wait for 4 weeks for a wound before we say it's actually stalled? And I think that to put timescales to wound healing is quite challenging. And I think that probably earlier intervention, we might see better outcomes, rather than waiting for it to be stalled for a number of weeks.
Mm-hmm. Not just for economic reasons, but also for physiological ones. I agree. Yeah. Another question, Brenda. Do you have you seen any side effects, any intolerance of Woulgan in the patients you observed?
No, the majority felt more comfortable. I think there was one report of pain, but whether it was associated with that, I think there was some confusion at first with possible worries about infection, and I think that again is understanding what it's like when you first treat him with the Woulgan. But other than that, not really. And on the ones where there was no significant change, I think that was seen fairly early on.
Mm-hmm.
So, yeah.
Actually, we had the same experience, not in a controlled trial, but in roughly 20 patients that we treated. Not all showed improvement, which is normal in such hard-to-heal wounds, but several showed marked improvements, and also especially a good cleaning effect and a resolution of sludge and sometimes even necrosis. So obviously also the autolytic process is induced. And beside of this, maybe phagocytosis also in clinical condition, not just in the lab. Yes, Bibi, and then in the back.
A practical question, how often do you have to apply it? Just once a day, or can you
Usually twice weekly, standard, but there were some in the evaluation that were weekly, sort of weekly dressing changes. There was one that was excluded that was used every day, which is not really advocated. So, yeah.
Mm-hmm. Thank you. Next question, please.
Well, actually, it's not especially a question. I'm Jacinta Wilming from the Netherlands. I'm an equine veterinarian, so not a point of view. I'm working for 15 years in wounds, treating wounds in horses, and what we see is that the problems in horses are mainly caused by the fact that the acute inflammatory response is not sufficient. So the way treatment and healing can be improved a lot is by stimulating the acute inflammatory response. In fact, a little bit like the beta-glucan. And what I use a lot is, for example, the alginates that also are said to stimulate the macrophages. You see enormous difference in healing. If you go in the beginning, if you start treating the horses with relatively acute wounds with the alginates, you see new formation. So you act with the physiology or the pathophysiology, and then you stimulate the formation, the inflammation, and formation of healthy granulation tissue. And after that, you see a better wound contraction, which is desired. But what we see very clearly, I always use the stimulating thing until the wound is completely filled with healthy granulation tissue. And then you have to stop because otherwise you overstimulate the processes and the inflammatory response, and you get, indirectly you will inhibit healing. So because we were talking about when do you have to use, how often do you have to use it, what I do in another type of species of animals, I use it in the beginning, I use it until it's necessary, and of course during every bandage change when bandage changes are necessary. So in fact it's a similar approach in another species, but with another product, because I used the alginates, but it might be very interesting for equine wound management too. So that's from another perspective.
Interesting.
Thank you for this comment. It's enriching to compare this, and there may be some similarities, but also differences, because in chronic wounds we have a chronicity with all problems associated, as you know.
But there are many similarities between the chronic human leg wounds and chronic equine wounds.
Okay,
and by the way, tomorrow we have a symposium, veterinary symposium, and that is one of the things that's coming along. But nevertheless, in fact, equine wounds are a very good model for non-healing human leg ulcers. So that's true.
Thank you for that. I don't see any further comments, and we want to be perfectly in time, which we are now. So I thank you for your attention. I thank the speakers for the excellent contributions. I thank Woulgan for hosting us, and I wish you a nice afternoon. Thank you.
Thank you.
eerste die ik tegenkwam.